Welcome to today's webinar about Class 5 composites and rubber dam isolation. While we are waiting for the participants to join the session, I will introduce you to our company. Dentist Channel Online is a digital dental media company. It is your marketing solution for dental events, product launches, workshops, and courses. We also provide a collection of scientific articles and blogs about different topics in dentistry. We work hard to be your first hand information on the technological advancements in the dental field. Now it's time to start the session about Class 5 composites and rubber dam isolation. If you have any question about this topic, please feel free to ask it in the question and answer box, and we will answer each and every question at the end of the session. I will start by introducing today's session speaker, Dr. Kalim Pop. Dr. Kalim Pop is currently practicing as a restorative dentist in Abu Dhabi and Dubai, UAE. Prior to relocating to the UAE, he was the founder and owner of Dentimed Clinic Romania, one of the top dental companies in the country. He is the author of the Rubber Dam Master Online Course, a bestseller course about integration of rubber dam isolation in everyday restorative dentistry, translated in 5 languages. The course is rated 9.4 over 10 on CourseMarks. Dr. Kalim Pop conducts over-the-shoulder courses, workshops, hands-on about restorative dentistry and also rehabilitations with ceramic restorations with all the modern protocols covering every single step: planning, photography, smile design, impression, 3D scan, rubber dam, and much, much more. Cover and author of the Rubber Dam First article in Journal of Cosmetic Dentistry, Fall 2020. Welcome, Dr. Kalim Pop. It's our pleasure to have you with us.
Thank you very much for the invitation once again. This is the second webinar this week. I hope that many of the participants from yesterday, they are also here today. I hope I made them curious about how to isolate one of the most difficult scenarios in dentistry. With rubber dam class 5 is quite a challenging situation. So thanks again. I don't know what to say anything else about me. You said it already. Just to add something that is actually quite obvious, I'm an avid promoter of the rubber dam isolation. If you go on my Instagram, everything is blue from the beginning of my Instagram till the end. And I do it with a lot of passion. Everyone who has visited my social media pages, they will see that I'm actually posting sometimes 15 minutes videos about procedures, not only like a glimpse or like something that just to make people curious or just to brag about the way I isolate and I work. No, I actually do it from the genuine passion to share what I know and what's working for me, what's making my life easier in everyday dentistry. I want to share it with my colleagues. I have a tremendous satisfaction when I have a feedback saying that thank you for this, you made my day easier, or I learned this and that. So this is what's truly worth it in all my efforts to do this. And yeah, that's quite obvious. This is something that I want to add. I don't want to start talk about the advantages of the rubber dam because we will devote 3 hours for this, and I will not be finishing. So I'll try to keep myself to the subject of this webinar, which again is class 5 composites with rubber dam. And this is quite challenging. I mean, people are very easily tempted not to use rubber dam in class 5 composites. They're just placing cotton rolls and suction. But let's admit, this is quite challenging, especially when you are working in the lowers posteriors, okay? You have tongue, you have a pool of saliva, you have the cheek. Cotton rolls are flying everywhere. Your assistant is like blocked in the position of acting like a cheek retractor and suction machine. So she's not free to collaborate with you in handling instruments. Sometimes you need 2 assistants for a very simple procedure. So once you place the rubber dam, your field is set, okay? You have freedom, you have visibility. Deep margins are now available for proper layering. You have more light. So there are a lot of advantages in working class 5 composites with rubber dam. This is, okay, coarse can be a solution to obtain retraction of the soft tissue next to the fret margins, but it's all about the way you can set your area to work with a lot of satisfaction, to be able to focus on the procedure, not being interrupted by letting the patient rinse every now and then. And sometimes the patient is rinsing, he's asking a question, he's checking the cavity with his tongue. Why do it take so much? All these things that are distracting us from the normal procedure. I have to mention something. I did also yesterday the same explanation, and this webinar, a big part of this webinar is pre-recorded. Why? I will be here. I will be live. I will check your questions in the Q&A section. I don't go anywhere. I will even stay at the end of the webinar to answer some of the questions, or all of the questions, if you will. But I do it pre-recorded because I'm presenting tons of videos from live cases. These videos are very hard to edit and to be brought in front of you if I don't pre-record it. I cannot speak at the same speed I'm showing videos. Okay, so you have to understand, and I apologize for this. It's not that I don't want to be live. I will be here live. It's just that it's one thing to just show a photo and talk a half an hour in front of a photo or a slide or wherever, like a table or statistic, which is, I find it boring, if you ask me. And it's a totally different thing to deliver information in a very intense way, a lot of videos captured from a camera that I have here on my loops to let you see exactly what I see during my work. So that's why most of the content that you see today, it will be pre-recorded. Okay, I'm here with you. I will check your questions. I hope that you are ready. It will be extremely exciting. Stay tuned, and we start in 5, 4, 3, 2, 1. Ready? So let's start with a live case where we can go through all the details and all the tips and tricks about the integration of the rubber dam isolation in treating class 5 caries with direct composites in the lower premolars area, and understand how practical and beneficial absolute isolation can be, especially in this situation when we encounter certain challenges due to the position of the area to treat. Okay, first of all, I'm using a periodontal probe to evaluate the depth of the caries in relation with the sulcus and decide if the procedure is really possible without violating the biological width. Because in some situations, the cavities are so deep that a crown lengthening is required. But this is another subject. We can explore how to integrate also crown lengthening in the same session with restoring with rubber dam. But in this case, I anticipated that the procedure is possible without the crown lengthening. I'm starting by giving the anesthesia. As I have mentioned with other occasions, I prefer intraligamental anesthesia instead of giving a full block in the mandibular area. For premolars, even simple infiltration will be enough. However, I prefer to administrate a small amount with infiltration, just enough to make sure that the intraligamental anesthesia doesn't hurt. This approach will reduce the anesthesia's effect and the duration on the surrounding area where I actually don't need it. I'm also anesthetizing the lingual mucosa to avoid any pain that the clamps or floss might cause in this area. Following that, I will continue with quadrant isolation, just like described in all the modules and bonuses about performing posterior isolation protocol from the Rubber Dam Master online course. So let's go through all this, simulating the position of the clamps with my fingers while the assistant is marking the position of the holes, because in this way the entire rubber sheet frame setup will go in the desired and planned position. I'm using the second hole from the puncture to perforate for the molar, because non-latex sheets, the one that I'm using, are very flexible and resistant to tear. Using latex sheets, you might tear the rubber when you want to pass it over the wings. Then I will gradually decrease the size of the hole as I move towards the canine. I include the canine in the isolation because I want to have proper retraction on the mesial side of the first premolar. Then I start by placing the master clamp in the perforated hole in the rubber sheet. Ergonomics are extremely important in rubber dam isolation, from the positioning of the hands, fingers, the body posture, the position from where you see the clamp, where you put your head. Is it on the left of your hands, the right, in the middle? Everything, every gesture is relevant to make the placement of the clamps smooth and safe in all scenarios possible. As you can see, I'm pushing the clamp in the middle of the mouth, and from here I'm heading to the anchor tooth. All these to have enough reserve of material against the buccal commissure and reduce the tension of the sheet next to the clamp. The index of the left hand supports the clamp to have more control and safely place the clamp without traumatizing the gum and prevent the sheet from rotating the clamp towards the mesial, okay? Because the sheet is basically pushing the arch, the bow of the clamp by rotating the clamp, and is pushing the clamp to the mesial. Then I simply push the sheet over and under the beaks of the clamp using only my fingers, no spatula or probe, because it can get really annoying while trying to grab the sheet with the end of the spatula, or even with a probe you can punch, you can tear the sheet. I'm also pushing the sheet under the wings to let the sheet slip towards the tooth and obtain intimate contact. After this, I place my index and middle fingers of both hands under the sheet as I'm positioned behind the patient at, let's say, 11 o'clock, okay? And I start manipulating the sheet in such a way that I am distributing each hole to each tooth to be exposed, and then ask my assistant to take over, hold the sheet in the obtained position, while I start using the floss to push the sheet through the contacts. As a separate note, as I have mentioned many times, I usually check the contacts before to see if there are any overhangings, calculus, or anything else that might prevent the sheet from gliding freely through the contacts. If that's the case, I'll use a diamond strip to make the contacts accessible. Also, some lubrication with the floss soaked in glycerin is very useful, especially when we encounter very tight contact points. If you use, by example, Vaseline instead of glycerin, you have to be careful to properly wash the area and even use some alcohol and clean everything so you don't have remainings of Vaseline on your working area. At this step, the quality of the rubber sheet is quite crucial because a low quality sheet will easily tear once we try to force it with the floss through the contact. It is also essential to use the floss ligature on the distal of the molar to push the sheet through the contact. Now here we have two options. We can either place a full floss ligature over and under the clamp, which I do most of the time, and actually this is the only way to have 100% inversion of the sheet on the clamped tooth, or at least, like in this case, to simply floss the distal of the molar to just to make sure that the sheet is passing through the contact with the next tooth towards the distal. The next step is to secure the sheet from the most mesial exposed tooth, the most mesial point, which is in our case the canine. I'm using a floss ligature, 4 hands technique together with my assistant. I will actually send everyone an email with the link of the video about the floss ligature, so you can play it as many times as you like and learn this way of making the floss ligature. Okay. So it's really important that my assistant waits until I get a good grip on the floss on the lingual side, so I can hold the floss engaged in the sulcus with a spatula while she's tightening the floss from the buccal side. If she's in a hurry, the ligature will jump away from the tooth, so I will tell her to wait until I confirm that she can start tightening the floss. What I also do, I tell her to keep the floss inclined downward. So if she's here, she has to keep her hands a little bit more in a downward position. For the same reason, to prevent the floss from losing the position at the sulcus level from the lingual side. I'm also showing her from which end to drag more or less, just to avoid any tangle of the floss that might prevent the knot from smoothly gliding all the way down. Once the knot reaches the tooth surface on the buccal side, I let go of the lingual part, I move it to the buccal, and then I push the knot deeper in the sulcus. Then I take over the ends of the floss, I move one to the lingual and keep the other one to the buccal, just to be able to have more grip and to be able to force, to secure the ligature by tightening it all the way down. Notice that at this point, while making these short circular moves, the floss is engaging deeper in the sulcus and it is basically disappearing under the sheet while it is inverting it. I've mentioned many times that I like to hide the knot towards the lingual side, but this is just a personal preference and I do it for the sake of the photos. Obviously, the floss will not be enough to retract the sheet, even the underlying gum, to expose the cavities on the 2 premolars. So I anticipate that we have to use additional clamps. Although I'm a big fan of the cut B5 clamp, it seems that I can't use it on the second premolar because the arch of the B5 cut clamp is too long and it is hitting the master clamp on the distal. So I decided to place the clamp B4, which is shorter, and it's actually doing a perfect job for this task. I even tried to place a B4 clamp on the first premolar, but of course with the arch oriented to the mesial to be able to have access on both premolars at the same time. But somehow I felt that B4 is not strong enough for this tooth and it doesn't have enough stability. Therefore, in this case, I'm using my favorite clamp, which is B5 cut in half. Just a short note here. When you cut the B5 or the B6 from the Brinker Coltin set, they are almost identical, by the way. It's just a difference in the angulation of the beak. But let's say I prefer more the B5 for that purpose. So in order to obtain a pair of cut B5s, we need to modify, to sacrifice two original clamps, because when you cut, the arch is not useful anymore, the arch on one side. When I'm placing the clamp, I always engage the lingual beak first, because the gum is thicker and I use it as support. And then I focus, once after I place the clamp on the lingual and I feel that I can rely on this position, then I focus on the buccal side where the situation is more delicate and I have to place the beak below the level of the caries lesion while retracting the gum in the same time. Any lack of precision at this step might cause some injury on the soft tissue. At this moment I may encounter another issue. Basically, I don't have enough force to push the buccal beak over the margin, especially in the scenario of deep lesions. Due to the mechanics of the setup, in order to engage the buccal beak, I have to rotate the forceps. So if I do this, I lose the position of the lingual beak. That's why I maintain the lingual beak in place and I use another instrument like the end of a dental mirror or a spatula to push only the buccal beak in a deeper position. So all this time I'm not losing the position of the lingual beak. Next step, I manipulate the sheet with a spatula or a probe, or even better, a small ball-ended probe, just to get the sheet in intimate contact with the tooth in the cervical area and also to obtain inversion. I'm able to obtain and maintain inversion of the sheet in this way in almost all situations without the need of the floss ligature over and under the clamp. I will start cleaning the caries. I'm using a long shank burr because in this way I have visibility on the treated area. If I used a short burr, the head of the handpiece will block the visual axis. Also, it is crucial at this time to support the head of the handpiece with the index of the left hand to have more control while prepping and avoid any accidental touch of the sheet with the burr, because in this way you can easily tear the sheet and lose all the isolation that you have obtained already. Just imagine that you do all this procedure without rubber dam. How hectic the process can be fighting with the cheek and the tongue. With rubber dam, you have space, visibility, gum retraction, and your assistant is free to manipulate both suction tubes to let you work continuously. So you actually gain a lot of time. I'm switching to a carbide Longshan burr for low speed handpiece to continue the prep in the dentin. Especially with this burr, the control is crucial because if it's touching the sheet, it might tear it. That's why the index of the left hand is always on the head of the handpiece, providing extra control. Also, the middle finger of the right hand has always support as a fulcrum on the neighbor teeth to obtain better control on the handpiece. Let's not forget a very important factor for this matter, which is magnification. For many years, I'm using 5-time magnification and I can't imagine performing this kind of dentistry without it. After the completion of the caries removal, I prefer to bevel the enamel surrounding the cavity in order to remove the broken enamel prisms. That will provide better adaptation of the composite, better blending of the composite on the margin, and also will slightly increase the surface of the enamel margins. These Arkansas stones are very easy to shape against another diamond burr, so you can customize them as needed. As the cavity extends towards the cervical when I prep with Arkansas stone, I prefer to reposition the clamp and re-expose the prepped margins. While doing this, my assistant is holding the sheet because if I detach the clamp, the sheet can slip over the margins of the preparation, and this is the critical area where I need clearance. I want to see the margins so I can reposition properly the clamp. I am pushing again with the spatula on the buccal beak of the clamp while I keep the lingual beak engaged in the sulcus, so I don't lose the position on the tooth. Once I see that the beak is passing the prepped margins, I can let the clamp sit and I remove the forceps. Now, of course, since I lost the inversion by moving the sheet, I will manipulate the sheet again against the sulcus to regain inversion. Then I do selective etch, since I'm planning to use self-etch 7th generation self-etch adhesive. While drying, I'm keeping the air syringe tangential, not perpendicular on the surface of the cavity, to avoid over drying of the possible etch dentin, because it is impossible to really etch only the enamel margin. My assistant is removing the moisture with a small suction tube, but be careful, as a small note, as a small trick, don't let her touch the margins, because the etched enamel prisms are quite fragile until you bond on it. The adhesive is applied and left to action for 30 seconds, as it is important to allow the self-etching process to take place if you are using this system. Then air syringe again to evaporate the solvent. I blow the air until the layer of adhesive is not moving. If you use a 6th generation bonding system, of course you'll have the primer and the bonding separately, so you don't have to do this because you don't have solvents in the bond. So you really have to adapt on the kind of bonding system that you are using. I'm cleaning the excess of the bonding from the rubber sheet, but this is just a personal preference, just because I like to have a clean surface as much as possible when I take the following photos. Next will be a thin layer of flowable. I'm using Fissura from LMArte kit to manipulate the flowable to uniformly fill the base of the cavity and also to remove any air bubbles. The first flowable layer is also important to reduce the increment of the next layer of bulk composite and overall reduce the stress caused by the shrinking of materials during the curing process. When I'm applying the next layer, I'm totally addicted to this tactile and flexible soft instrument. It is like a brush made out of silicone, and it's extremely useful, especially when you want to create a convex surface. If you want to create this type of shape with a spatula, it's quite difficult due to the flat and rigid shape of the active metal tip. So with this spatula, it's very easy to shape the composite. Then I'm wetting the silicone brush in composite modeling resin, designed for use as a composite sculpting resin. Basically, it's much easier to manipulate the composite with this wet silicone brush. And I do this to avoid also the composite sticking to the brush and to be able to smoothly adapt the material to all the margins. Then I will take the Fissura and remove the excess of the material. I don't mind if I can't remove the overhangings completely on the beak of the clamp, as long as I'm sure that the margins are properly closed. I'd rather prefer to have an overhanging that I can reduce and polish later on than to have an open margin. Everything goes the same for the second premolar. I do the last cure with glycerin in order to remove the oxygen inhibited layer. For those who don't know this aspect, when composite is light cured, oxygen in the air causes an interference in the polymerization, resulting in the formation of an oxygen inhibited layer on the surface of the composite. So basically we have to use something which is transparent because we need a light to action on the composite, and in the same time to block the oxygen, to prevent the oxygen to interfere in the curing process. In this way we will have a fully converted layer, because otherwise if you have uncured resin, the layer of the composite will get easily stained and it doesn't have the same strength like a fully cured composite. To be able to remove the excess of the composite without damaging the surrounding surface of the tooth, I'm using again the Arkansas stone, but I shape it as a long thin burr to be able to remove all the overhangings. When it comes to reducing the overhangings on the cervical, you might be tempted to remove the rubber dam. On the contrary, I prefer to still keep it on while only removing the clamps, and I'm retracting the sheet from the cervical area just enough to expose the gum. In this way, I still benefit from the retraction of the cheek, visibility, and of course, light. Then I am playing with the sheet. I push the sheet towards the mesial and then to the distal, and this is gently retracting and protecting the papilla and offers good visibility on the peripherals of the cavity. To polish, I switch to a brownie tip. I personally use Edenta tips. I really love the small size that offers great control on the polishing process. It is a polishing tip for high speed, so make sure you are using a micromotor, not a turbine, because in this way you can reduce the speed and avoid the heating, and also you don't put too much pressure because brownie is quite an active polishing tip and it can't remove some of the composite, so you might excessively reduce the nice contour that you have created with the brush. Then I'm switching to the green tip, again from Medenta, in the polishing sequence while still maintaining the sheet in place. I cure again with glycerin to block the oxygen, just as an extra precaution related to the oxygen inhibited layer aspect, as I have mentioned. Then remove the floss with any sharp instrument or probe, and I remove the sheet, and I prefer to cut actually the interdental parts of the sheet with scissors, but of course I have to pay attention not to cut the patient's tongue, cheek or gingiva. After the rubber dam is out, you can do some extra polishing with your preferred polishing setup. And then I like to observe and check if any overhangings are left so I can remove them if the case. Okay, so let's continue by observing the integration of the rubber dam isolation in an even more difficult scenario. For example, deep caries defect in lower molars extending under the gum. Again, like I have explained in the premolars case, I want to highlight the advantages of performing the entire procedure on the rubber dam isolation rather than struggling with retraction cords and cotton rolls, because visibility and access are again a problem in this area, not to mention how difficult it is to control the saliva and the tongue. Again, I'm using a periodontal probe to see if the restoration can be done without invading the biological width and to determine if a crown lengthening is needed or not. In this case, I anticipate the fact that the cavity will not extend significantly towards the cervical even after the cleaning of the caries defect, so I decide to start the procedure by administering the anesthesia. Like I've mentioned in the premolars chapter, I prefer intraligamental anesthesia and avoid a full block that will anesthetize all the surrounding areas unnecessarily. But there is a small trick here. When you inject, be careful to inject very slowly, because if you inject too fast, the tooth will extrude and you will have a high restoration. So just inject slowly and you will avoid this problem. I got asked what kind of syringe I'm using, and I think this is not so relevant, it's not so important. However, just as a personal preference, I like the stylus type and I find it easier to control than the gun type. In terms of ergonomics and positioning of the hand and control, I think that the stylus syringe is much better. Then I switched to a normal syringe to add just a small quantity of anesthesia on the lingual side, because I want to avoid the pain caused by the clamps and the floss. But as a small tip, if you just wait a minute after you administrate the anesthesia on the buccal side, then it is not so painful on the lingual. Otherwise, I admit that the patients are complaining, because even so, this might be a little bit more painful than usual. You can also use more enhanced systems like STA, single tooth anesthesia, like WAND or Calaject or Quick Sleeper. Everything follows as I described in the posterior isolation modules and bonuses from the Rubber Dam Muscle online course, with marking the position of the holes while simulating how the sheet will be held by the clamps. Don't forget before inserting the sheet to floss the contacts before to see if there are any overhangings or calculus or anything else that might prevent the sheet from gliding freely through the contacts all the way down. If you haven't recently done the scaling for the patient, it is a good idea to use the ultrasonic for a quick assessment of the quadrant. Even if it's bleeding, you don't care, because obviously you will have a good isolation. I often use a diamond strip to make the contacts accessible. Also, some lubrication with the floss soaked in glycerin is very useful, especially when we encounter very tight contact points. At this time, I'm not sure which clamp to use due to the deep position of the defect. I'm exploring to see if 13A, the clamp that I usually prefer as a master clamp, will do the job, but I noticed that I can't obtain a proper retraction and exposure of the defect. The beaks should go in a much lower position, much deeper position, so I tried to push the buccal beak with another instrument towards the cervical. Since it was quite difficult to obtain this position, I preferred to let the sheet in place and glide the sheet over and under the clamp, like I actually usually do when I use wingless clamps. But most of the sheets, especially the latex ones, will surely tear when you try this approach with a winged clamp, because of the fact that the perforated hole has to extend considerably to pass over the wings. Also, the quality of the puncture is important at this step, because if you don't cut a clean hole, the sheet will most probably tear. I also have to mention that I've used some lubrication on the inner side of the sheet to facilitate a better gliding. Sometimes I use Vaseline, but I really have to clean the sheet after I establish isolation, and especially I need to wipe with alcohol everything to make sure that all the Vaseline is gone before proceeding with restorative and adhesive procedure. Then I'm using a spatula to drag the sheet from the distal to fall next to the clamped molar, and I continue with pushing the sheet over the wings of the clamp, and everything follows as I described earlier in the premolars case. I can't say that I'm very pleased about the level of the retraction next to the cavity, and again I use the spatula to try to obtain a deeper position of the beak. Then I'm using floss ligature over and under the clamp to invert the sheet under the beaks. However, the isolation and inversion are far from being perfect, and I feel that I need to change the clamp. But in the meantime, I just prefer to start prepping and explore how deep the margins will be and eventually decide later on a better clamp. My everyday, every case long chamber that allows good visualization of the cavity. But again, I'm using red ring handpiece 1/5 multiplication because I have better control and a lot of torque, so I can dial the speed down without losing the torque. Even if you have this systems with a pedal and you can control the speed of the air-driven handpiece by pushing the pedal all the way down or just a little bit, when you decrease the speed of the air-driven handpiece, you lose torque, so you don't have precision. Basically, the burr will stop on the tooth. So that's why I almost never use the air-driven one. Instead, I'm using the electric handpiece. Don't forget to always find support for your right hand, keeping your fingers on the neighboring teeth, and also the left hand is controlling the head of the handpiece. This is crucial not only to have precision when doing the preparation. When you work so dangerously close to the sheet, any touch might tear the rubber. And again, magnification is also important for this matter, extremely important. Now, to obtain better inversion at this step seems to be a lost cause for me. I'm trying with a spatula, but as you see, it is impossible. So from this point, I actually presume that many of you are tempted to give up, to remove the sheet, to remove everything, and just use a retraction cord. But think again, have a look and see where the tongue of this patient is, not to mention the saliva and all the impediments. Cotton rolls will fly everywhere in this mouth. So for me, I don't see any other solution than to try to obtain better isolation using another clamp. Keep everything in place because I don't want to redo the flossing on the premolars. And again, if you're still tempted to give up and use traditional way, have a look on the level of the salivation of this patient, just in case you are still tempted to continue the case without rubber dam isolation. Notice that while selecting the clamp, I'm still keeping the sheet in place with my left hand to prevent the sheet, the entire setup, to jump off from the premolars. I place the clamp while retracting the sheet from all sides with the help of my assistant, of course, and then use the probe to rearrange the sheet in an intimate contact with the molar. Although I obtain a much better retraction next to the cavity, I'm still not happy with the inversion of the sheet on the buccal side under the beak of the clamp. Then I bevel the margins to obtain this infinite transition for better blending of the composite and also to gain more enamel, as I have mentioned in the premolars chapter. No issues to invert the sheet on the mesial, but it seems impossible under the beaks of the clamp, at least for the moment. Low speed handpiece. I'm using carbide burr to finalize the cleaning of caries indenting. Again, supporting the head of the handpiece with the index of the left hand. It's crucial to avoid any accidental slipping and damage on the rubber sheet. To solve the issue of improper inversion of the sheet under the beak of the clamp, I'm using Teflon that I will condense in the space which is limited by the beak of the clamp and the tooth itself, or basically the margin of the preparation and the beak. I can add one more piece just to make sure that the space is filled and the soft tissue and the sheet are compressed and retracted in a lower position. So everything is nicely isolated now. So now I can carry on with sandblasting. Then actually I sandblast also in the premolars case. Maybe I forgot to film and to insert this part of the video, but I always use sandblasting. Then selective etch, since I'm planning to use this 7th generation self-etch adhesive. I'm using 3M universal bonding, by the way, but you can use any systems you are familiar with. sharp probe to remove any bubbles and to allow a uniform adaptation in the cavity. Then again, the magic silicone brush, my everyday tool to adapt composites in all the scenarios possible. I'm also condensing with Fissura from LMRT and alternate with a brush to smoothly adapt by literally dragging the material over the margins of the cavity. I'm keeping the tip of the brush slightly wet with modeling resin just to be able to smoothly glide over the composite and adapt it on the margins. Cure and add the last increment to restore the convex surface specific in this area. Again, I don't mind if I can't completely remove the overhangings on the beak of the clamp as long as I'm sure that the margins are properly closed. I'd rather prefer to have an overhanging that I can reduce and polish later than to have an open margin. This is such an amazing instrument. Look how nicely the adaptation process goes. As I've mentioned, I will send everyone an email and I will send you the link of this from where you can purchase this instrument. Again, I don't have anything with this company, I'm just sharing the good word about this nice instrument. The final layer is cured. Again, don't forget the glycerin. And then, as you have seen in the premolars video, I'm shaping an Arkansas burr to start the finishing sequence. I retract the sheet with a spatula while working with the stone next to the cervical margins just to avoid tearing the sheet in that area. To polish, again, I switch to a brownie. I really love the small size that offers great control, as I've told you, on the polishing process in this, let's say, delicate area. I repeat myself saying that it is a polishing tip for the high speed, so make sure you reduce the speed of the micromotor to avoid the heating. And also, don't put too much pressure. This brownie tip is amazing. If you want to reduce composite, you can reduce the composite just by pushing a little bit more. If you want to polish, you don't push. So if you are happy with the contour of the restoration that you have obtained with the silicone brush, just don't push the brownie, don't put pressure, because you might reduce the nice contour that you have created with the brush. Okay, so we saved the best for last. Let's see another case with class 5 lesions in the anterior area and understand the integration of the rubber dam isolation and all the advantages of this approach in treating such cases where actually you can find either caries or sometimes just cervical erosion, named in the literature NCCL, non-carious cervical lesions, or like in this particular case, all defective, open margins, overhanging old composites. Now the challenge here is to isolate while dealing with old overhanging restorations which are extending under the gum level. You might be tempted to remove the old composites first and only after that to actually place the isolation. However, I prefer to place the rubber dam first in every situation before touching any old restoration. Let's first review some aspects of the ergonomics in approaching this area and understand the importance of every small gesture in order to obtain a fast and relaxed workflow. So after marking the sheet while simulating the position of the setup on the face of the patient, I respect all the techniques described in the modules and bonuses about anteriors from the Rubber Dam Master online course. Basically, first I'm just distributing the holes to match every tooth I want to isolate. I don't bother at this time with the inversion. I just want to see that everything is in the position and held in place by the clamps number 2. So basically I place the clamps number 2 on the first premolars without perforating the sheet, because I just need to hold everything in place and provide retraction to the distal. Let's review actually the positioning of the additional clamps. To isolate the two centrals, I'm actually using cut B5 clamps from the Brinker set. I mean, this is the original B5, the butterfly clamp, which is cut in half, as you have seen in the premolars case. I stopped using B4 clamps to isolate anteriors because they have a quite fragile stability, and the B5 cut clamp is much stable and provides more space because it has longer arch. Once I feel that the palatal beak is properly engaged in the sulcus, I can focus on the buccal beak. Exactly like I have explained in the case with the premolars, due to the mechanics of the setup, in order to engage the buccal beak, I have to rotate the forceps. So you don't have, the only way to engage the beak over the margin is to rotate your hand. So while doing this, you lose the position on the palatal beak. That's why I improvise sometimes and I use another instrument like the end of the dental mirror or a spatula to push the buccal beak in a deeper position while I'm not losing the position on the palatal beak, but just be careful because if you use something that is slipping away, you can really hurt the gingiva. Once I'm convinced that the beak is sitting above the margins of the cavity, again, magnification is really important at this step. You really have to see what you are doing. I can let the clamp sit on the tooth. Then I manipulate the sheet with two instruments at the same time, a normal spatula and a ball-ended probe. And this is extremely useful to drag the sheet in an intimate contact with the tooth. You might say that this is quite difficult to work with both hands at the same time because you're not ambidextrous, but let's face it, we as dentists are ambidextrous. We are always using both hands during the procedure. What I notice here, actually, if I'm not using the B4 clamp, but the B5 cut, which is longer, I actually can keep the forceps with the ends in the same position that I've used to place the first clamp. I don't have to rotate like I've shown you in the ergonomics module. Due to the anatomy of the B5 cut clamp, the forceps is not hitting this time on the arch of the previous clamp like it would have done with the B4. After I place the clamp, I use these two instruments again to manipulate the sheet and invert it in an intimate position next to the tooth. And again, my favorite every day, every case, long chamber to start removing the decay and eventually switch into a sharp one once I dangerously get closer to the sheet, just to prevent tearing it. Arkansas to remove the broken prisms on the margin of the cavity. In this particular case, you notice that the gum has invaded the cavity. So in order to let the sheet properly invert and expose the margin, I have to use laser, I have to trim the gum. But I don't have to remove the full setup. I just retract the sheet and then I laser the excess of the gum and I reposition the clamp and then carry on with all the steps you have seen in the premolars and molar cases. Sandblasting, etching, bonding, layering with the silicone brush, finishing with Arkansas stone, pre-polishing with brownie, and then I can remove the sheet so I can reduce any overhangings on the cervical. Arkansas stone is amazing at this step and it doesn't cause any trauma on the soft tissue. Then I gently pre-polish with brownie, but without pressure. I mentioned why. Because I don't want to remove the nice profile that I have created with the brush. Then you can do the final polish with whatever is your favorite system. Last cure under glycerin and the case is finished. This last photo is actually after 1 week. Okay guys, so I'm curious about your opinion about using Robodam in class 5 composites. Do you find it difficult? Do you have any questions? I will be more than happy to try to answer it here. So as you noticed, I only presented live cases from real struggle, real dentistry. The patients that you have seen, there were actually patients who paid for the procedure in real time. I work in real time. Okay, I stop once in a while. I take the photos. This is my passion, and the patient understands. Otherwise, nothing is produced. Everything is live dentistry. Okay, so I see now Siamak. I love you. I love you too. Bala Gopal, thank you. Great work. I loved it. Very nice presentation from Dr. Bhupinder. Thank you for the nice words. I appreciate your enthusiasm and your love for nice restorative dentistry. Shoot any question about Robodam and restorative dentistry, not only about Robodam.
Dr. Callan, I would like to thank you for sharing your knowledge and for this amazing webinar. Very, very nice cases.
Thank you.
I'll ask your permission to introduce our company to all the participants. And meanwhile, the participants, I ask them to put their questions in the question and answer box, and we will answer every question.
Just let me do something really fast, because I open a link with a discount for my Robodam online course. I will present it after, before the questions. But just that this link is valid starting from now. I just open it. So anyone who is interested in more than whatever I've presented now, this is just a small segment. I'm pasting the link here, and it's a hectic discount for the course, and it's valid until midnight today. So I just felt that I should put this link here for whoever is interested in the course. Of course, I will stay here after your presentation and I will answer all the questions. So meanwhile, guys, if you have any questions, just feel free to drop it in the chat section and I will be more than happy to answer it. Okay, thank you, Sarah. You can do.
I'd like to thank you for this offer for our participants. It's a really great offer. I will share my screen now, and after that, we'll take the questions.
Of course.
So this is our organization, Dentist Channel Online, Healthy Smiles, Wealthy Lives. I will introduce you to Dentist Channel Online. It's a leading dental media company that aims to spread awareness and knowledge regarding various aspects of dentistry. We conduct regular webinars and courses on different areas of dentistry. Being a Prime member with Dentist Channel Online brings you several opportunities, accredited webinars, and dental courses. If you're not a Prime member yet, kindly join our family to get free certificate of participation after every event and get exclusive discounts and offers on our paid online workshops and courses. Being a Prime member with Dentist Channel Online will give you a lot of benefits and will cost you less than $7 per year. So this is an example of the certificate of participation that you will get after every event. About our upcoming webinars, we have two webinars on Friday, December 17, one with Dr. Ahmed Al-Fiki from Egypt about anomalies from orthodontics perspective, and another one with Dr. Jasmine Haddad about how to instantly deliver world-class patients experience, minimize complaint, grow your profit without burnouts. On Sunday, December 19, we have two sessions, one with Dr. Sneha about sports dentistry, a new career dimension in dentistry at 11:30 a.m. Indian Standard Time, and another one with Dr. Zafar Abbas about aesthetic facial anatomy, happening on Sunday, December 19 at 1:30 p.m. Indian Standard Time. Dr. Ibrahim Abdelmunim from Egypt will give two sessions about bonding in dentistry, one happening on Sunday, December 19, and the other one on Sunday, December 26, both at 7 p.m. Indian Standard Time. Dr. Mahmoud Ramadan, also from Egypt, will give a session about implant-assisted overdenture on Sunday, December 26 at 5 p.m. Indian Standard Time. About our upcoming courses, we have an on-site course, implantology course with Dr. Mohammed and Dr. Anuj happening in Cochin on January 6 until January 9, every day from 9 a.m. until 7 p.m. Indian Standard Time. So I request all the participants to kindly save this number and then send a message with their name on WhatsApp, so they will be added to our broadcast list and they will receive everything about our upcoming dental webinars and courses. Today's webinar is sponsored by Novamind. Novamind offers a full spectrum of implants and prosthetic solutions that accommodate any clinical need in modern implantology. We successfully supply highly demanded dental implant types called internal hex, tissue level, bone level, and active conical connection. Our EU production unit and product quality is appreciated worldwide. Dental implants and dental restorative solutions produced maintaining all the standards of EU medical device regulatory. Products are manufactured in Athens, Greece, and distributed worldwide with more than 1 million happy restorations. So if you want to know more about Novamind, kindly check their website. Last but not least, don't forget to follow us on our social media platforms, Facebook, Instagram, and YouTube.
Great. So I can see already a question asked by Dr. Asta Lakul. I hope I pronounced correctly. She's asking how to place rubber dam in the class 2 cavities, which is near the bone. Placing the floss ligature may affect the placement of the matrix band. Indeed, it's quite challenging, but also there are some tips and tricks how to do it. Let me just share the screen with you. Let me show you another case where actually I didn't know if it's a class 2 or class 1. Sometimes you just start and you have some surprises. I mean, you remove the old feelings and then you will see the real situation. Just as a note, I'm always placing the rubber dam before starting the preparation, and this is an amazing advantage in some situations. For example, sometimes you have class 2 cavities with overhanging old restoration, and the overhanging itself helps you glide the sheet under the margin of the preparation. I will finish this case and I will show you what I want to say with this. But here it looks like a class 1. However, when I removed the sheet, it was a class 2. Imagine in this area next to the gum, how difficult it is to push the rubber dam if you don't place the rubber dam before. Because now you have sharp margins, you have some maybe some bleeding from the gum, you have saliva, everything is in dark, you cannot see, so you are struggling to place the rubber dam before. That's why I never drill and then see what's happening and then I place the rubber dam. This also helps me. It offers me visibility. Look how nicely I can see this deep margin. Imagine this is the gum here. So going back to the question of Dr. Asta, I have the clamp. I have a class 2, okay? I have the floss ligature who nicely inverted the sheet in the sulcus. I have the clamp and I have another floss ligature here, like you have seen me that I've presented in the webinar. The floss which goes over and under the clamp. By the way, as I promised you, I will just paste the link of it's a YouTube video with my floss ligature module. So I will just go in the chat section. Where's the chat section? Okay, after I will explain this case. I will not forget. It's copied already. I will just paste it. Remind me if I forget, okay? So class 2, clamp, floss ligature. The rubber dam is nicely retracted and I can go ahead and place and do a nice class 2 restoration. First, I transform the class 2 into a class 1 and I finish the restoration. Of course, the other teeth, the same. Okay, as a small trick, sometimes, let me go back here. Sometimes the beaks, the medial beaks of the clamps, of the master clamps, indeed they are in the way of the matrix, clamp and wedge system. Yeah, sometimes due to the anatomy of the tooth, depending on how deep the cavity is, this part is interfering. Now, maybe here it was not because the clamp is a little bit inclined because of the rubber dam, which was pushing on the bow of the clamp. However, sometimes I just cut the medial extensions of this clamp if I feel that they are interfering with the wedge, ring, and matrix. I don't use a wingless clamp because I still need the wings to retract in the back, especially in the lower, that I have the tongue, the cheek, everything is tension and strong. I need the wings to push everything down. As you notice here, these wings are pushing everything and they are retracting. If I use a wingless clamp, the sheet will stay like this next to the tooth and I don't have too much freedom to work around this tooth. So just cut this section, just take like any bird, like the one you used to cut metal crowns, cut it, polish it, and use it as a customized clamp for this situation. Okay, Dr. Asta, let me just show you the case how I finished it. So this is a class 2 on the premolar and on the molar. The molar, I've scanned it and we delivered a nice onlay. But again, if you noticed in the delivery session, rubber dam is in the same position. You might be tempted to say that this photo belongs to this session, but actually is not, it's the next session. But because I'm confident on the clamps that I'm using, on the protocol, everything looks the same. This is the core. Once you know the rubber dam protocol, you don't have any fear that, okay, can I isolate now? You don't live with this fear. You just know. But of course, it takes a while to master the techniques. That's why, again, I encourage you to take the Rubber Dam Master online course, which I still believe is the most valuable resource nowadays worldwide in terms of learning proper rubber dam isolation. It's not just me talking. I have a lot of colleagues saying this. The course is full of live cases like you have seen in this presentation. And it's useful for beginners, also for advanced, not advanced, okay, let's say not advanced, but for dentists who are already using rubber dam. However, they feel that they need some improvement in some particular places. Just a small trick will make the difference in terms of helping you. For example, after I launched the course, what did I do? I continue to keep in touch with all the dentists who were attending the course. I have a chat section in the course where every dentist can ask any question, and I'll, within a span of like 1 week, let's say, if I'm busy, I will go back and answer the question. But sometimes I feel the need to put new content, new bonuses. This is how I added the floss ligature bonus. I added the class 5 with composites bonus that was in this webinar. I added a bonus about ergonomics, where actually, because what happened, I had my colleagues in the clinic, and all of them, they have attended the Robodyne online course. However, they told me I still struggle with this and that, and I didn't know why. And then I had a good look on them, like while working, and then I noticed the hands are not in the proper position, the head is not in the proper position, they are literally going over the patient, looking from here and from here. So I understood that it's all about ergonomics, which in my case, because I do it for many years, I didn't bother. But then I observed that my position of the hand is different than theirs. Then I put a module in the course which is called Hands, that dealing with ergonomics. How to hold your hand is one thing to hold your hand here, then you cannot see the clamp because of your wrist when you're placing the clamp, and a totally different story when you keep the forceps from down. Your hand is next to the body, you are relaxed, you have visibility. A small gesture, that's it. Just put the hand in a proper position. It's like skiing or swimming. Every small gesture is important for the workflow. So yeah, this will be an amazing and valuable resource for anyone passionate and interested in the Robodyne fail. Dr. B is saying that he tried to pay for the Robodyne online course. Unfortunately, the payment failed. I'm not sure. Let's keep in touch. Doctor, I'm just pasting my number here. Let's keep in touch after the webinar on WhatsApp, and I will ask my team to support you. Okay, so this is my number. Just
Doctor, you wanted to paste something else, link or something?
yes, I will do it now. So this is my number. I hope I spelled correctly. 520. Okay. Feel free to just text me. Okay. For any problem, and this is the link with the floss ligature bonus. It's so tricky. So feel free to watch it, you and your assistant, until you master it, because also this is an important thing in the workflow. The nurse has to do the floss ligature, and then she's helping you. I explained this in the bonus. It's a 4 hands technique. We are placing the floss. In one particular moment, I take over and I tension the knot, and in this time, she's going back to the table and do the next knot. So then you gain a lot of time. You are working continuously. I'm also pasting here something that I promised yesterday, and I did actually. This is a link, because many dentists ask me about which are the clamps that I'm using. And this is a link. Just download the PDF with everything that I'm using. Robodyne, clamps, frame, puncher. You will see photos and explanations in this video, in this PDF.
Yes. So I think that's it for today. We don't have any other questions. Oh, we just have. Thank you, Doctor, for good presentation.
Yeah, Dr. Ananta, thank you very much. Thank you.
So
thank you, guys. Let's keep in touch. Let's keep in touch on my social media. You have my number. Once again, I do it from my passion to share my knowledge and to try to help dentists not to go through all the struggle I've been for many years. When I was younger, I wish when I was younger to have access to such courses, these webinars, all these nice ways of us communicating and sharing knowledge and information, and from all over the world. This is amazing. I didn't have this when I was younger. I wish I had, but I didn't. So I had to go through all these mistakes that you have seen in the webinar yesterday, and all the struggle that is normal to have when you try and you explore and you want to learn. So it's good that somebody will tell you, this is the mistake, do it properly.
Yes, so I would like to thank you again, Doctor, for this nice presentation.
Anytime.
Very nice pictures, amazing pictures. So thank you again for sharing your knowledge and your experience with us. We are looking forward to organizing more webinars with you in the future.
Super. Thank you.
I would like to ask the participants if anyone did not attend yesterday's webinar, you can find it on our YouTube channel. It's already there. Okay, it's about 20 mistakes in rubber dam isolation and how to avoid them. So thank you everyone for joining us today, and don't forget to check our upcoming webinars and courses.
Thank you. And see you online. Take
See
care.
you. Bye. Bye.